Good afternoon. Hi, my name is Vinh Nguyen. I'm one of the general internists here in the section of general internal medicine. My talk today is about how doctors get paid. A little bit about the past, present, and what grim future we see. I have no disclosures, no conflicts of interest. My learning objectives, one is to describe the events that shape the development of insurance in this country, mostly health insurance, not the other types of insurance. Also understand the documentation requirements for certain levels of E&M coding, and also understand some upcoming federal initiatives that will definitely impact our physician payments. So physicians has been around for quite some time now. I mean, basically since the dawn of time, or many centuries ago, physicians would come and perform their services, heal the sick, do the things that similar to what we do today, and then they get paid for their service. So it may not be cash or outright, but maybe some kind of product or services, chickens, grains, what have you. But prior to the 1920s, the medical technology and procedures were not very advanced at all. So for most part, medical expense was very low, and the most costly thing to people were that if they got sick, they were unable to work, so they lost their wages. So that was the most costly thing to them. So there was this idea of something called sick insurance. Basically, what that is sort of like our modern day disability insurance, where someone got sick, they lost their wages, so this insurance would kick in, and they will basically pay for their lost wages. And this idea was been around for quite a long time, even in the 1800s or so. So with more and more advances in medical technologies and better medications, there was some interest in national health insurance, where basically universal coverage for everyone. But at that time, lawmakers were not too keen on this idea, because the low current cost of medical costs overall, and also the insurance companies saw it as a really unmanageable risk, where they were not sure, there's no data for them to assess the risks of the patient. See what people will be the overutilizers, the underutilizers, or the ones that will just not use the insurance at all. So in the 1920s and 30s, there was more improvement in the medical procedures, and more drugs came out to improve outcomes. So then came the supply and demand. So there was a big shift from people living on the farms to living in the cities. So as more people moved into cities, they lived in closer quarters. So there was more chances of people spreading diseases, so more people became sick. So plus there's the more demand for medical services. But at the same time, there was less providers. At that point, the AMA, American Medical Association, started instituting requirements that practitioners be graduates of an accredited medical school. Thus, since that was a requirement, then medical schools started to toughen their requirements, more admission requirements, and toughen their standards for graduation, thus further depleting the supply of physicians and healthcare practitioners. Around the same time, the American College of Surgeons started to set some standards for surgeons in hospitals, so thus further depleting the supply of qualified practitioners and hospitals. So with all of the advancements in medical technologies and in drugs, there was more demand on medical care, and thus more demand on the household's budget. So it became more and more that more and more the people's budgets were dedicated to healthcare, medical costs. So in a group of Dallas teachers, they decided to negotiate with Baylor University Hospital for prepaid hospital service. Basically, it was paying $6 for about 21 days of hospitalization. It's pretty cheap in these days. But for the most part, it was good for the hospitals because they had a steady income. So they knew where their revenue was coming, and that's good for the insured because they at least have some type of prepayment for hospitalization in case they needed it. So the idea caught on, and many other hospitals joined together and offered their own hospitalization coverage. And as more and more plans got together, the American Hospital Association then decided to bring all of these plans together into one plan, which they referred to as Blue Cross. And so the problem with Blue Cross was that they only paid for the hospital bills, not the physician bills. So physicians at that time were not too keen at joining on the bandwagon at that point. I mean, they liked their independence. They liked to be able to charge whatever they felt their services were worth. So they didn't want to get into their own plan at that time. But as time went on, the idea of this prepaid hospital plan became more popular. And so the AMA developed some guidelines for these prepaid policies to cover these physician services. And then in 1939, the first prepaid plan for physician services opened and was called the California Physicians Service. These plans were basically stepwise plans where people with low income would pay a smaller amount, whereas people with high income would be paid a larger amount. And in 1946, all of these plans were reorganized into one group, which they called Blue Shield. So I found this quite interesting, where I didn't really know where Blue Cross and Blue Shield actually started from, and in researching this talk, it became quite, I guess, interesting. So then in came the insurance agent industry. So Blue Cross and Blue Shield were basically non-for-profit organizations, and which they use what they call a community rating system, in that everyone basically paid the same premium for type of coverage, no matter how much services you used up. So the overutilizers were paying the same premium. People who are healthy, young, don't use the system much, they pay the same premium. So in came the insurance industry, where they say, well, I could make more money off of this. They instead use an experience rating system, where the premiums were based on certain claims. So as time went on, they knew that, I guess, whenever you apply for insurance, you have to put down how much, how sick you are, what medical illnesses you are, just as it is these days. But they use that system, that type of information, in order to gauge what premiums that the insured would pay. So it's not hard to see that the insurance company basically targeted the young and healthy people to get onto their plan. It was appealing to the young people because, I mean, they pay much less than what they would pay for the Blue Cross Blue Shield. But then they drew all the insured to their plans. The insurance industry did. So during this time was when World War II started in the 1940s. So with World War II, there was a shortage of workers. So most of the workers, qualified workers and all, were in the military serving there overseas. So there's the 1942 Stabilization Act, which basically put on wage and price controls during this period of time. It basically prevented employers from offering high wages in order to prevent workers from moving from one job to another because of the high wages. So because of this, employers couldn't entice or other workers to come to work for them, so then they decided, but they were permitted to offer insurance plans. So this is the beginnings of our modern day employer-based hospital plans. So during this same time, manufacturing was a boom in the US economy as well. So along with the manufacturing boom and labor unions negotiating wages and all, along with these couple new law rulings, it basically paved the way for employer-based insurance as we see it today. So the first ruling was the War Labor Board. This was the federal agency that was in charge of labor during the war, and it ruled that employers could not cancel or modify any group insurance during their contract term. Then later on, after the war was over, the National Labor Relations Board took over. Basically the same thing, were in charge of labor. It ruled that medical insurance was part of an employee's wage. So for most part, you couldn't change the insurance, the contract term, and it was part of the employee's wage. So at this point, the federal government liked this idea of employer sponsored healthcare plans. So they started to encourage more of these plans to be formed, and therefore they made medical insurance premium exempt from any payroll taxes. So it thus continued to influence that trend towards employer-based plans. And then later on, the medical premiums that was paid by employers, since they were actually wages, they became not taxable income. So thus further influencing the shift towards employer-based plans. So what about the uninsured? In 1958, about 3/4 of all the people in the U.S. had health insurance. But what about the other quarter of the population? They were mostly uninsured. Well, most of the uninsured were either sickly or elderly. So in 1965, Congress passed the Social Security Act, which created Medicare and Medicaid. So what is Medicare? It's a government-sponsored health insurance that's paid for by our payroll tax deductions. It's basically divided into two parts. When a person reaches the age of 65, people are automatically enrolled in this program, Part A, which provided hospital coverage for the elderly. And then came Part B, where we say basically insurance that covered for services provided by physicians, essentially Blue Cross and Blue Shield in that respect. And nowadays, Part B is concerned, they also pays for certain outpatient services as well. Then recently, I guess, when President Bush, George W. Bush was in office, he signed into law the Medicare Part D, which offers prescription drug coverage. And Medicaid was created to address the need for insurance for those that were not employed, not elderly, and not insured. So it was a joint program between the federal and state governments to provide medical coverage for the indigent. Essentially, the federal government gives each state this, a subsidy, essentially, to provide care for the indigent population. And the federal government would set the standard for what they determine as indigent. And every state is different, and each state is free to decide to expand their coverage if they wanted to. But there was a certain minimum coverage that's guaranteed by the federal government. So that's a little bit about the past. So where are we here now today? So in this day and age, we basically, the predominant reimbursement model is fee for service, which essentially healthcare providers are paid for each service they provide. So I'll be the office visit, a test, some procedure, whatever the service is, you submit a bill and you get paid for that service. So essentially it's volume based. So critics of these fee-for-service model feel that it encourages people to do more tests, to do more procedures, and really doesn't take into account the quality of the care. It's just basically volume. The more people you see, the more you make. So that's a little bit about how physicians get paid nowadays, but what about hospitals? They have these things called diagnosis-related groups, or DRGs. So essentially, before the advent of DRGs, people got hospitalized, and the hospital basically tallied up the bill and sent it to the patient, which was retrospective. As far as for diagnosis-related groups, DRGs, the purpose of this was to provide us prospective way of billing, of getting income. Basically, how it was made was that the whole idea was to divide everything up into 3 different major categories, 23 different major categories. And within each of these major categories, they were further divided into these diagnosis-related groups that was based on their surgical status, age, comorbidities, their discharge status. And then all of the diagnosis codes, which I'll talk to about a little bit later, the CPT codes, were pushed into all of these DRGs. And then so whenever someone comes in, gets admitted, then depending on what their diagnosis is and what their comorbidities are, then they get placed into this DRG, this diagnosis-related group, and that determines how much payment the hospital will get. So as an offshoot of the the original DRG, Medicare made something called the MS-DRG, which is the Medicare Severity Diagnosis-Related Group. This is the most commonly used DRG these days. And it takes into account 3 levels of severity. You have the major complications and comorbidities called MCCs. There's the complication comorbidity called the CCs, or there's non-complication or comorbidity, or the NCCs. So essentially, suppose you have a patient that comes that has peripheral vascular disease, had a stent bypass in and had a stent in and came in for stent thrombosis. So that in of itself is a DRG itself. So if they had no other comorbidities, then the hospital would get paid a certain amount for that. So just suppose that the patient also had a history of congestive heart failure. So it doesn't have to be an acute exacerbation, you just have a chronic systolic congestive heart failure. That qualifies as a comorbidity or complication. Well, basically a CC. It's not acutely, so if it was an acute exacerbation, it'll be a major complication, but since it's just a chronic thing that's present there, that determine it has a comorbidity there. So the resources the theoretical resources that the hospital would use to care for this patient is more than it was for a patient that without this congestive heart failure diagnosis. So therefore, it's more complicated, more resources devoted, so therefore deserves more pay to the hospital in that respect. So that's why you get these things from the case managers all the time saying, if they have these complications, make sure you list it. So that way the coders can properly code to put these patients into the correct DRGs. So what about this alphabet soup? What's all these abbreviations mean? ICD, V codes, CPTs, E&M. Well, as far as ICD and V codes are concerned, these are diagnosis codes. So ICD has all of these, diabetes 250. So these are just diagnosis codes. V codes are basically there for comorbidities. So if you have significant family history of cancer or so, then it can be coded as a V code. Whereas CPT and EMM are service codes. So you get CPT bill 99231 or 33 or so. Those are CPT codes. So first thing is ICD. It's short for International Classification of Diseases. This was developed and maintained by the World Health Organization. It's used to classify morbidity and mortality. It promotes international comparability, so used for research and epidemiology, and it's revised periodically. Now we're currently in the 9th revision, and 10 is soon to come. It's supposed to be implemented already, but it's been delayed a few more months. So like I said, the ICD-9-CM is clinically adapted from the ICD, so it's a clinical modification. This gives more detail and specificity to the disease classifications, and it supports the medical index, record indexing, and standardizes the utilization billing. This is revised annually, whereas the ICD itself is periodically revised. So with all of this, I mean, okay, sure, you see a patient, you make the diagnosis. Is that enough to justify you get paid for it? Maybe not. So for most part, you have to meet this medical necessity. So anytime you see a patient or provide a service, you have to make sure that it was medically necessary to perform this, to see the patient. What was the reason to do it? So the definition under Title 18 of the Social Security Act said that no payment may be made under Part A or Part B for expenses incurred for items or services which are not reasonable and necessary for the diagnosis or treatment of illness or injury or to improve the functioning of a malformed body. So just remember, I mean, anytime you do something, you have to make sure that it was medically necessary to do it. Well, CPT is short for Current Procedural Terminology. It was developed in 1966 by the AMA for codes for surgeons. It was then expanded in the 1970s to include medical procedures and services. So, and then in the 1980s, the federal government adopted the CPT coding across all medical specialties, and thus made this the de facto coding standard for all medical billing. So, CPT codes are 5-digit numeric codes. It covers all billable services and procedures, quite extensive. It has 6 main sections, and as you see, the anesthesia section, the surgery section, so all surgical procedures are in that surgery section. Radiology, pathology, laboratory, the medicine section, which has like EKG, stress tests, and echoes and all in there, and E&M management. So what I'm going to concentrate most on is this E&M, the evaluation and management section. So what are the components of evaluation and management, E&M? So you must have history, physical examination, and this medical decision making. Other things that you can bill on are basically time-based billing, which majorly composes of counseling and coordination of care. So what are the components of a history? Everyone knows you need a chief complaint. So what is the reason why the patient presented? Why are you seeing the patient? Could be just follow-up of diabetes. That's an office visit. That is a valid chief complaint. Okay, but it's usually in the terms of the patient's own words. And then there's the history of present illness. So it's a chronological description of the development of the patient's illness. So it should include some of these elements. So these 8 descriptors. So location, quality, severity, duration, timing, context, modifying factors, and associated symptoms. You should, the more you included this, the more comprehensive the evaluation is. So then you have the review systems. It's basically just an inventory of the body systems and just to see if there's any other symptoms. And the recognized systems by CMS are included here. These 14 systems: constitutional, eye, ENT, cardiovascular, respiratory, and so on. And then the other part of the history is the past surgical, family, medical, social history, or FISH for short. So past history, as one knows, illnesses, operation, injuries. Family history is anything that's relevant to the patient. And then social histories is whatever age-appropriate review of the past and current activities are. So the different levels of history. So once you take the history, you put in, I guess, this little matrix where you can tell how comprehensive of a history did you obtain. So as you can see, the chief complaint is required for all of them. So if you miss the chief complaint, then it's not a valid EMM visit. You won't get paid for it. So if you don't document a chief complaint, then you're lost. And then the HPI, depending on how many elements of the descriptors you have. So 1 to 3 only gets you a problem focus or expanded problem focus, whereas 4 or more will give you detailed or comprehensive. And then the review systems, 1 system, and 2 to 9 for detailed, and then 10 or more. So as far as 10 or more is concerned, you don't have to list them all, or you can just list some of them and then say all others are negative. And that should suffice for CMS. And then the FISH, you have the past family, social history, then you have 1 history, and then or 2 or 3 for the complete. So here's an example. So you see a visit with a 27-year-old female with mild pleuritic chest pain for 3 to 4 hours after exertion. She has wheezing. She has a history of mitral valve prolapse. She has an asthmatic brother and a smoker, and she's a smoker. So review systems otherwise entirely negative in detail. So what level is the history? Basically, it's actually a comprehensive history. You have the chief complaint, which is the chest pain. The HPI has 5 elements to it. It has mild, pleuritic, happened 3 to 4 hours after exertion with associated wheezing. Okay? And then you have the FISH. So history of mitral valve prolapse, she has an asthmatic brother, and a social history, she's a smoker. And then review system was complete since it said otherwise entirely negative in detail. So you met all of the, in just that one little statement, you met all of the history components. I wouldn't recommend you writing this in the chart network, but, but just for documentation purposes, this is sufficient for billing. And so, how about examination guidelines? Well, there were two different guidelines that were set out. First in 1995 and then revised again in 1997. You can use either one, but you shouldn't mix and match 95 and 97 guidelines in the same E&M visit. So you can use one for one visit and another one for another visit, but don't mix them in the same visit. As far as why use one over the other, the 95 guidelines are basically more, I guess, advantageous for the general internist. And when it first came out, all of the specialists and all basically were up in arms saying that, wait, we're specialists. We don't go through all of these organ systems and body areas all the time. So then that's when they developed the 97 system where they can focus on more their particular organ system. But as far as the 95 guidelines is concerned, you can use the body areas, which includes all of these, plus each extremity is considered a body area. So right upper extremity, right lower extremity, left upper extremity, left lower extremity, all of those are separate body areas. And as far as organ systems are concerned, they have all of these listed here. So how do you get the levels? So depending on how many systems or body areas or organ systems you examine. So if you just focus one, then you just examine the affected area. Expanded is just, it's an examination of the affected area, but not without an extended examination of that affected area. And then the detail has to have an extended examination here, and then the comprehensive is basically all of them, or majority of them. Basically 8 or more. So as far as the 97 guidelines, again, you can use the general multi-system one or the single organ system, which is all of these things here. So for most part, the 97 guidelines, or they are also referred to as the bullet guidelines, where you have all of these little bullets that you're supposed to meet, check off basically. But I'm not going to go too much detail into the 97 guidelines. So as far as the general system is concerned, you do 1 to 5 elements identified by bullet, like I said. And then that's 6 for that, and then detail, you have at least 2 elements by bullet from each of the 6 areas, or 12 elements by bullet in 2 or more system areas. So it gets quite cumbersome counting bullets and all. And no one really remembers all of it. So most people, they just revert back to the 95 guidelines instead. As far as the single organ system, you can do basically the same as the other one, but the major difference is the detailed and the comprehensive. So for the comprehensive, you have to perform all the elements identified for that organ system. So just some reminders for examination portion. Is the physical finding performed during that current encounter. Whereas the history, you can refer back to previous history and update whatever that was updated. This one is, you have to document what's in the current encounter. This specific abnormal and relevant negative findings of the examination of affected area or symptomatic areas should be documented. A notation of abnormal without elaboration is not sufficient. Abnormal, unexpected findings of the examination, any asymptomatic bodies or organs should be described. But if there's an unaffected or asymptomatic organ system, you can put normal or negative there, and that would be sufficient. But if it's an affected area, then you need to elaborate. So, an example of a physical exam. So, no jaundice, EOMI, no lymphadenopathy, clear auscultation, regular rate and rhythm, soft benign, abdomen, positive bowel sound, no clumping cyanosis or edema in the 4 extremities, and alert, awake, orient times 3. What is the level of this physical exam? So you have a bunch of body systems here. So skin, eyes, the hematologic, there's the respiratory, cardiovascular, GI, the musculoskeletal, and then the neurologic. So 1, 2, 3, 4, 5, 6, 7, 8. You have 8 systems there, so it qualifies by 95 guidelines. You qualify for the comprehensive, given 8 organ systems and body areas. So now we move on to medical decision making. So this is the third portion of the CPT code for E&M. So medical refers to the complexity of establishing a diagnosis or selecting a management option. So you have the number of possible diagnoses and number of management options, and the amount of data that you review. So laboratory data, EKGs, radiology data, and then the most, I guess, most tricky part is this risk assessment. So risk of significant complications, morbidity, and or mortality tied to those problems. So with all of this, reading through the guidelines from 95 and 97, I mean, some of these things are quite ambiguous. You really can't tell what qualifies for a certain area. So, and Medicare saw this. So for the most part, they sent out this little point system to their Medicare providers, which made it a little bit easier to try to quantify what you're recording. And for the most part, that's what they use now as far as Medicare auditors are concerned. In order to, when they come in and audit your charts and all, they use this point system in order to decide what the level of service was. So as far as medical problem points, so you get 1 point for any self-limited or minor diagnosis. Yeah. If you have an established problem that's stable and improving, you get a point for that. You have an established problem that's worsening, you get 2 points. You have a new problem but no additional workup, then you get 3 points, but you only get a maximum of 1 of those. And then you have a new problem with additional workup plan, then you get 4 points. And then data points. So now you have your diagnosis, all of your list of problems. What about all of the data that you used to come up with that diagnosis? Do you get any credit for that? So in order to count those up, you review or order any clinical lab test. You only get 1 point for that. Doesn't mean that if you order CBC, BMP, coags and all, it's 1 point for each of them. No, it's only 1 point for any lab test. If it's 1 or 10, it's still only 1 point according to this system. Review or order radiology test, that's still 1 point. So CT, chest x-ray, only 1 point. And then review other medicine tests, so PFTs, EKG, echo and all, it's just 1 point. Discuss the results with the performing physician, there's still 1 point. Decision to obtain old records, 1 point. But if you review and summarize the old records, you get credit for 2 points. That's more work on your part, more complex, and you're summarizing it, so you get credit for it. And then if you independently view the image, tracing a specimen, not just the report of it, but actually see the images and document that you saw it and interpret it, then you get 2 points for that. And then there's this table of risks. I know this is very small, and you may not be able to see it all, but it's basically just a general guideline to tell you what the presenting problems were, what listed procedures that you can order, and the type of management options you have to select from. It's just for guideline, but it's not supposed to be used per se. But I broke it down a little bit to make it a little bit easier to see. This is the first two rows is minimum risk. So you have one self-limited or minor problems like a cold, insect bite, or yeast infection, then this minimal, then these little lab tests here, and then what your management options are. So low risk, 2 or more self-limited minor problem, 1 stable chronic problem, so on. And then what I'd like to point out is basically the moderate risk. I mean, as internists and all, we deal with a lot of chronic medical problems. So for the most part, if you list all of this, then you should get credit for it. So if you have 2 or more stable chronic illnesses here, that's already made it a moderate risk. And then any physiologic stress test, but other thing is prescription drug management. So just writing a little antihypertensive or oral hypoglycemic, I mean, that's prescription drug management. So it's a moderate risk. As far as high risk concerned, I mean, basically any IV narcotics, or any kind of drug therapy requiring intensive monitoring or toxicity, vancomycin, gentamicin, things like that qualifies for a high level of risk. And also the decision to do not resuscitate. So you make a patient DNR and start to de-escalate care. That's considered high risk as well. So this is the points table. So you tally up all your problem points, how many diagnoses and all you have, any data points that you have, what's the amount of data that you reviewed, and then the risk. And then you assess what's the complexity of the medical decision making. So is it straightforward, low, moderate, or complex? So you need 2 out of 3 to qualify for a given level of medical decision making. So for most part, if you have four points of problems, 1 point of just lab stuff that you reviewed and moderate risk, then it's the second highest. So your level of complexity will be a moderate complexity since you have moderate risk here and a high risk here. So that's how it goes. But if you have a minimal risk, then there'll be the straightforward one, since you have 4 here but only 1 and 1 here. Here's an example. You have an established patient visit. He comes in, you diagnose him with a new upper respiratory tract infection. It's mild, so you decide not to give him any further treatment. He has hypertension that's well controlled on lisinopril, and he has osteoarthritis that's controlled. So you decide to continue the naproxen and check a creatinine. So in this example, you have an established problem. You have no self-limited minor, you have an established problem. There's hypertension in the OA, so that gives you 2 points there, 1 each. And then a new problem, but no additional workup plan, so maximum of 1. But you get 3 points, so total points of 5. So just for the for that, you get the data points. I mean, you get 5 there. Okay. As far as the data, you only check the creatinine. So you review the order clinical lab test, so you get 1 point for that. The rest of the stuff you did not do. So you got 1 point for the data. So you have 5 points for problems, 1 point for data. And then you look up the risk. So like I said before, we can go back to here. So he had 2 or more chronic stable illnesses. So moderate there. And then you have prescription drug management because he's on lisinopril. So that's there. So it's moderate risk there. So moderate risk there, you have 5 points, which is high risk, and then 1 data point, which is straightforward. So that comes out to be a moderate complexity. Okay. So for that, but a little bit about time-based coding. So sometimes you have a patient that the majority of the time you do is counseling and coordination of care. So take it you have a diabetic patient that's uncontrolled. You come in, basically you counsel them about diet, exercise, make sure they check their sugars and record their sugar readings and talk to them about compliance, about medication. Suppose it takes the majority of your visit. And so if you spend more than 50% of that visit doing care coordination and counseling, then you can basically bill according to that time and not by all of those other E&M requirements that we just talked about. So, but if you do elect to report it based on the counseling coordination of care, you have to document the total length of time. It has to be face-to-face time, or in the hospital setting, floor time. So if you talk to somebody over the phone, that doesn't count. It has to be face-to-face. And it should be documented and record, and you also should document what is the type of counseling that you did. So this is some sample office visit codes. So this is putting it all together. So suppose you have a patient that you come in for a follow-up visit. So for most part, you need, in order to get moderate level 99214, you have to have a detailed history, a detailed exam, a moderate complexity medical decision making. So, and you only need 2 of the 3 required. So for most part, if you have detailed history, detailed exam, but a low complex, you still can bill at this level since it meets the 2 out of 3 requirement. But if this was a new office visit, then you need a more complex of all of this and the medical decision making to be moderate. So you have to have all 3 of them, 3 of 3 required in order to meet that level of service. Okay, and as far as this average time is concerned, this is what you use if you're just going to bill according to time. So you spent 25 minutes on that visit, and the majority of the time was for care coordination and counseling, then you can bill for that. And you don't have to worry about all of this other history exam, and you don't even have to document it. Basically, all you have to do is say that patient came in for diabetes follow-up, and greater than 50% of the time was spent in counseling the patient on diet, exercise, medication compliance, and checking sugars. But as far as good documentation is concerned, I mean, that's not good for your later colleagues who comes in and sees the patient when you're not there, and you don't have any documentation of what you actually did for that patient that visit. So as far as documentation and handoff is concerned, it's good to document all of that. But as far as billing is concerned, you don't need any of that. It's kind of contradictory, but it works. So that's where we are today. So just a couple upcoming trends. There's one of which is PQRS and meaningful use. So what is PQRS? It's a reporting program that uses a combination of incentive payments and payment adjustments to promote reporting of quality information by eligible professionals. So it used to be called PQRI. It's a Physician Quality Reporting Initiative. It was a voluntary system where people would just report quality data. So what type of quality data are we reporting? Basically, same types of data that you're already reporting on for core measures. So CHF, use of ACE inhibitors and beta blockers, or coronary disease, make sure they're on beta blocker or aspirin. All of that is part of this PQRS system. But the requirement for reporting is you have to meet 9 different initiatives. So what are eligible professionals? Basically anybody that accepts Medicare. So any kind of Medicare physician, MDs, DOs, podiatric, and as you can see, this list goes on and on. Nurse practitioners, including the advanced APRNs, and then therapists. So the whole idea behind the PQRS was to give the participating physicians or practitioners opportunity to assess the quality care that they're providing to their patients. You can also quantify how often they are meeting a particular measure, and it gives them some performance data to compare with their peers. So the reporting methods are Medicare Part B claims, where they attach these quality cares to the claims. You can register through a qualified PQRS registry or through your electronic health record using the certified electronic health record technology, or via data submission vendors or qualified clinical data registry. So what are the incentives? Why do all of this? So it was started in 2007, and basically it provided an extra 1.5% pay increase to all your available Medicare claims. So as it goes up, it went 2.5, then 2, 1.5, 2, then it started going back down. This is when, in 2013 was when the sequestration hit. So because of that, everything got across the board 2% pay cut. So this was supposed to be 2.5%. It had that sequestration did not hit, whereas this. So, but now it's at 0.5%. And that's where we are today, at 0.5. So what if we don't report? Well, in 2015, there's going to be a payment adjustment. So if you don't report these quality data, then you get dinged for it. So you get a 1.5% negative payment. So for practitioners and group practice participating in there, they will receive only 98% of their allowed Medicare Part B professional fee schedule amount. So basically, if you don't start reporting this, then you'll get dinged for it. And then in 2016 and beyond, you'll get a 2% pay decrease. For one, I asked the billing department, and we are not reporting PQRS data. And this PQRS data is tied to your NPI number, so it's per practitioner, not for the institution. And meaningful use. So basically the idea behind meaningful use is to use electronic health records to improve the quality, safety, efficiency, and reduce health disparities, engage the patients and family, improve care coordination, population, and public health, and maintain privacy. So ultimately they want to have better clinical outcomes, improve population health outcomes, have transparency and efficiency, empower the patients, individuals, and more robust research and data on health systems. So there's different stages of meaningful use. There's stage 1, which basically just data capturing and sharing. Then stage 2, which should be coming up soon, is advanced clinical processes. And then stage 3, which is later on. And all of these stages, you must use a certified electronic health record. So you can either choose to participate in the Medicare meaningful use or Medicaid. Every state has their own Medicaid meaningful use, but these are the differences between the two. So this one's run by CMS, whereas this is run by the state. The maximum incentive amount is slightly more for Medicaid, but it's spread across 6 years, and this is across 5 years. And payment reductions begin in 2015 for providers who are eligible but choose not to participate, whereas there's no Medicaid payment reductions if you choose not to participate. And in the first year, all remaining years, and all providers must have, they must achieve to get incentive pay. They must have the objectives. And then as far as the Medicaid is concerned, the first year, all you have to do is say that you implemented an EHR. And then in all remaining years, providers have the objectives to achieve, and just like the Medicare. So as for payments are concerned, the incentive payment is 75% of your Medicare allowed charge up to maximum. So the incentive is actually a little bit more than that PQRS, much more. So you started in 2011, you would have gotten 18 grand, so and your maximum would have been here, maximum start here. And then as you go on, you get there. And this is when sequestration hit, so then that's the reduction by 160 here, another 240 and 80. And then these are the stages. So stage 1, 2, and 3, which will be later on. So what are the penalties? So Medicare eligible who do not participate in meaningful use will have their reimbursement start at 1% per year up to maximum 5% annual adjustment. So if you don't participate in this, then you get dinged again, up to maximum of 5%. So who's eligible? Basically all doctors of medicine, osteopathy, dental surgery. They don't include practices, so these are just practitioners, not group practices. And no hospital-based, no groups, I'm sorry, and no hospital-based practitioner. That's defined as providers who provide more than 90% of their covered professional service in either an inpatient or emergency department of the hospital. So hospitalists these days, they're not eligible for this meaningful use. So the reporting periods, the first year you must meet the requirements for and report the data for 90 days, contiguous 90 days. The subsequent years you have to report for the entire year. So the stage 1 requirements, they have 13 core objectives, 5 of 10 menu objectives, and 9 clinical quality measures. So here, equals meaningful use. So what are the core objectives? The percentages here is what is necessary at least to qualify for that measure, for that objective. So if you're CPOE, at least 30% of your orders have to be CPOE. Drug allergy, maintain up to the problem list for 80% of your pages, e-prescribing 40% of the time, maintain active med for 80% of the time, and so on. And then the menu objectives, you need 5 of these 10. So you can pick either, you have to submit electronic data for this, or submit electronic, so one of the objectives has to be one of these 2. And then you can pick 4 of the rest, or you can take both of these 2 and 3 of the rest. But one of them has to be at least one of these. And then again, the percentage is what is required to meet the measure. And the clinical quality measures, from 2011 to 2013, you can choose 6 of the possible 44 measures. There's 3 required core measures and 3 alternate core, and the other 3 will be of the 38 measures. And in 2014 and then beyond, they upped it to 9 measures. So they come up with these recommended measures for adults and for pediatrics, but I just listed the one for the adults. So some of the core: controlling high blood pressure, high-risk medication, elderly, preventive care, so tobacco use screening for most part, and so on down the road. So once you're done with all of the data collection, then you have to attest that you collected the data and that the data is correct. So it's a legal statement that you have to met the requirements, and it's entered through an internet-based CMS system. So you log into the CMS system. That's how you register as well. So you log in, they ask you a bunch of questions that you fill in the data, and then you will check a checkbox to say that you attest to it. And then now we're currently in stage 2 that's supposed to rolling out. So it's similar to stage 1 in the core menu objectives, but the thresholds just increased. It just made it even more difficult. So you have 17 core measures plus 3 menu measures, and then the clinical quality measures equals the stage 2 meaningful use. So these are the core objectives. Basically similar to what you had before, but it records smoking status with 13 years or older. So now these are the 17 core objectives, and then the menu objectives are those. So submit electronic records, electronic notes, imaging results, record patient family health history, report the cancer cases to a central public health registry, and report specific cases to a specialized registry. So this basically refers to if you have like a flu registry, then you can report it to that. And then the CQMs, beginning must select 9 out of the possible 64. And the new requirements for that, the quality measures selected must cover at least 3 of the 6 available national quality strategy domains. These are the 6 domains that they want you to cover. So patient family engagement, patient safety, care coordination, population public health, efficient use, and then clinical processes and effectiveness. And that's it. Questions? I know it was a lot in a short period of time.
Do you have any idea how many first applications for payment are rejected and sent back?
I don't have the numbers, but for most part, I mean, I would assume that would be quite high. I mean, for most part, when they prepare, they have to put all of the different elements together and then submit it electronically. Most of the time, they spit it back and they ask for more data, basically. And then the billers have to put more data in and send it back again. So it's back and forth time. Sometimes it goes 3 or 4 times before a bill actually gets accepted.
So, now my wife's a solo practitioner. She has her own national health record, which is Athena Health.
Okay.
And she's met every one of these things along the way with a lot of hand-holding from Athena. She's gotten paid eventually, but quite a bit of money, actually. Now, what about those of us here? I know I haven't selected any 9 of 64 domains or any of that crap. So, are we going to be getting individually dinged?
Well, yes. Short answer is yes. I mean, if you are a qualified practitioner by their standards, an eligible practitioner, then for the most part, if you don't report the data, then you will eventually get dinged. Whatever Medicare.
Has anybody in this
Not yet. From what I understand, as far as stage 1 is concerned, the institution did good as far as stage 1 was concerned. But this stage 2 is quite more difficult to attain, and we may not even get there. It's a grim future.
Is the electronic prescribing to any drugstore in town, or just the LSU pharmacy?
No, LSU form, as far as the outpatient forms, they don't accept electronic submission of prescriptions.
But
So
aren't they working on it?
they're working on it, yes, but right now it's not working. So basically electronic submission to prescription to outline local pharmacies.
Well,
CVS
here's
pharmacy.
my point. I mean, a lot of us e-prescribe, a lot of us do all the stuff on the list. It's in Epic, it's all there, but we're not individually reporting it
Yeah.
to Jack?
I think that's a question for Dr. Mack.
And then, do y'all know which cancer registries or infectious disease registries to report?
I mean, they have further lists, and I didn't enumerate them to all of the registries that they have available, but for most part, they have a list of registries that you can submit to, and it's basically they leave it up to the practitioner to do all of this, and more, like I say, as time goes on, there's more and more of the physician time used to do all of this paperwork and office stuff instead of actually being able to treat patients. That's just the trend these days. I mean, I don't know what else to do about it, but that's the trend.
Well, I can tell you what they'll have to do about it. They'll have to pay Judy.
True. Hire somebody to do it for you, an office personnel or somebody.
And we already hired Judith. Referring to Judith Faulkner, the founder and privately held owner of Epic Systems, who, because we had these opportunities to make incentive payments for adopting Epic, our state tax dollars and federal tax dollars subsidized the purchase of Epic from Judy, who is a heavy contributor to the Democratic Party, and who was appointed to the national board that determines what kind of requirements health records have to meet in order to be so subsidized.
It's all a racket.
You know, this we would call conflict of interest.
Yeah, the COI, right? The disclosures.
Meantime, here we are, and we're supposed to individually report all this crap in order to not get dinged. Yeah.
I'm sure
There's a program coming
From Judy.
from Judy to help us out.
As a department, what policy have we adopted that we can be making these measures? Because in a couple of years, the punitive measures will be quite strict.
Yeah.
So I mean, University Health will probably not do this because it is at the individual practitioner level. And our billing is done still by the billing department of the med school, am I not correct?
From my understanding, yes.
So what have we instituted as a department or as an institution? Dr. Levine?
Ricky has sent a couple of emails about making some modifications in Epic that would make it not difficult to, what he said, the second stage of meaningful use.
I just wanted to bring this to everyone's attention. Yeah.
Well, but we're letting you do.
I see that. Got the bullseye on you. Any other questions? Thank you very much.